counties. So next up, I am delighted to introduce Dr. Shauna Fagan. Dr. Fagan is a PMS accredited menopause specialist and senior sexual health doctor with the Irish Family Planning Association. She's a graduate of Trinity College Dublin in 2014. She completed her GP training with Trinity College Dublin in 2019 and is a specialist interest in sexual and reproductive health. Shauna has been part of the Irish Family Planning Association since 2020, and she's an experienced LARC, and you'll explain that, Shauna, and contraception tutor. She has long-standing commitment to the education and training of healthcare professionals and to the advancement of evidence-based practice in community sexual and reproductive healthcare. So welcome, Shauna.
Hi everyone, my name is Shauna. Thank you very much for today. So today's a chunky enough topic, so menopause. It's a lot to cover in a very short space of time, but I'll give it a crack with lots of flowery wounds and uterus pictures around, so forgive me, I have a tendency to put them everywhere. So yeah, LARC is supposed to explain to people long-acting reversible contraception. So I do a lot of contraception work and then a lot of menopause and sexual health work overall. So yeah, first, lovely botanical picture. So what is menopause? I wanted to just go back to basics because I know everyone knows a lot of this, but it's no harm sometimes to go back and just go over the definition sometimes. So menopause is technically the final menstrual period, okay? There are transition points along this journey depending on how it happens, be it suddenly or gradually, depending on what situation you come to menopause with. So pre-menopause, obviously before all that, perimenopause is a time of great fluctuation and change. It's actually a time of high estrogen and low estrogen, which a lot of people are like, no, it's only low estrogen, but actually it's the volatility and the fluctuance of it that causes a lot of the carnage and chaos in the perimenopause. Now, you may not go through the perimenopause if you go by a surgical road to menopause. And then the menopause itself is just the final menstrual period. And then post-menopause is everything after that, okay? So a couple of definitions to be aware of. That early menopause is kind of 40 to 44, okay? And then premature menopause, or POI, or premature ovarian insufficiency, is any menopause that takes place less than 40 years old. I would say over 45 is kind of the typical menopause era. Just to give an idea of the different kind of things that we look at when we're going through into a menopause. So again, this is just kind of making the point that there are lots of roads to the same pathway of menopause, and everybody can be a little bit different in how they got there. So people with BRCA, how do they encounter menopause? They can go what we say is the natural physiological way through menopause, in that maybe they're diagnosed with BRCA or aware of BRCA at a later stage, and they go through the menopause at the normal time. You can have what we call an iatrogenic menopause, so if you have your risk-reducing surgery, or you can have an iatrogenic menopause after cancer treatment, and we're particularly interested in potentially a hormone-sensitive cancer that has some implications on what treatment options are available. And it can be chemotherapy or radiotherapy induced as well, not just surgical removal of the ovaries. So I think it's thankfully people now know the symptoms of menopause. There historically, it was quite brushed over, but thankfully that seems to be different now. But what I'd say is like, there are so many symptoms of menopause. There's literally not one symptom that I could take and say, well, could this be related to menopause? Yeah, sure, it could. There are some typical symptoms, so things that we particularly ask for. So we call them vasomotor symptoms, so flushes, sweats, all of that jazz. They can actually present as cold as well. That's so people are like, oh, I don't feel hot, but I feel shivery and cold. And that can actually be a vasomotor or sweat as well. Brain fog, decreased concentration, issues with sleep, vaginal dryness. These are all very typical symptoms of menopause. It can be hard to narrow down sometimes because you can be like, well, I know I'm different, but I don't know what the difference is. So sometimes having a validated questionnaire can be really useful, especially if you're going into a GP who we know are time sensitive, sometimes appointments, and you sometimes feel you can't get it in your head. These type of questionnaires can be really useful to send in advance of time. And this is just one of them, the green score. There are loads of them. I want to point out that Menopause Society of Ireland exists, and it's a relatively new society, but there's lots of resources there for patients in terms of questionnaires and everything, which I find really, really useful. There's also a couple of like resources for insomnia and everything that can be great. So it is just worthwhile knowing that they exist. This is just a long list of books. There's, while I'll acknowledge there's a limitation here on books specific to cancer-related menopause, but I just wanted to give something for people to have a look at. And again, this is listed on the Menopause Society of Ireland website. The next one here is very kind of busy, okay? And I was like, oh, I'm probably when I put it up or not. This is called the straw reproductive aging, okay? So what I want you to take from this is there are just different transition points that different things happen, be it with your menstrual cycle or biochemically on a blood test. And again, some people jump straight in here. They don't go through the transition point depending on what's happened to them in their life, and that's fine too. But it just gives you an idea here of what you might expect coming when, if you were to go through a physiological menopause as such. So kind of down to the meat of it, so management of the menopause. So there are some common principles across the board in the management of the menopause overall. But what I want to say is that a physiological menopause is more of a winding path. There are kind of different times with different needs along that path. And testosterone is very popular to discuss. So testosterone levels can be actually kind of unchanged in the perimenopause on a day-to-day basis. There was this kind of thing, it's like, okay, 3 hormones in the ovary, 3 hormones that needs to be replaced. And there is some truth with that for sure. But actually our testosterone levels are naturally declining since our 30s on a more gradual basis. And the postmenopausal ovary, if it's there, actually still produces some testosterone. So it's not the same flip edge that we get with estrogen. So with estrogen, it's like, oh, and it's gone. Whereas testosterone is much more gradual, and as such, we can accommodate a lot more often in our bodies. The exception to this, so if your ovaries have been removed, that's an abrupt loss of testosterone, okay? It's very, very dramatic, and a lot of people in that circumstance really do benefit from testosterone supplementation if it's an option for them. But I suppose as well, the other big thing to say is if you have personally had a cancer diagnosis, that does mean that we have to be careful in what treatment options that we consider first line. I never want to say never, like I just don't go to buy into that school of thought. It needs to be an individualized discussion with both like the doctor and the patient in front of them about what they want, like because your quality of life is ultimately the most important thing. And risk is important, and we have to talk about risk for sure, but it's not the only thing. So I never say hormone sensitive cancer is a no forever for hormone therapies. It's a strong consideration not to, but if the person really wants it or needs it, well, then it is certainly a discussion to have, okay? So this is kind of an outline of the management options. I will try to blow through this. It's a lot of management options in the menopause, but essentially I'm going to briefly touch on the non-medical, touch on the medical non-hormonal, so things I can prescribe but don't have hormones, and then the medical, a little bit about the vagina and a little bit about bones, okay? I should mention contraception here. It's not relevant for everybody, but it's something, if it is relevant and applicable to your situation, to not forget, okay? The time of the perimenopause is actually a time of maintained fertility. If you have the organs available that are needed for contraception, you should consider it if it's not something that you want at this stage of your life, okay? And period and cycle management, again, if it's applicable to you, HRT and menopause hormone therapy is not a treatment for menstrual disorders by itself. There are things like merino coils and stuff that can be very relevant. And again, depends on your individual situation, but just not to forget about these things. So non-medical, I kind of bore myself to tears a little bit with these slides because I'm like, everyone knows this, okay? When I say the same things over and over again to people, like, you know, if you could reduce your smoking, safe alcohol use, movement, healthy weight, social connection is one that I really want to highlight because I think it's not said out there as much as it should be. Like, so true social connection is a real dementia prevention agent, okay? So seeing your friends and seeing your family and having good connections with people, any people that you can, is very healthy for your brain. I say prioritize your sleep because, like, realistically, good sleep is not always realistic, but to make it a component of your life that you address can be a very valuable thing to do. Diet, and we kind of mentioned supplements. My big one is vitamin D. Like, I can kind of take or leave the rest of them. Take vitamin D, okay? We live in Ireland, there is very little sun, and to be honest, you would like break your back trying to get enough sun to get vitamin D. So take vitamin D. You don't need to take calcium if it's in your diet. There's a really nice online Edinburgh calcium intake calculator, so Edinburgh the city. You can calculate if you need calcium in your personal diet. Usually you don't. Protein, again, a very, very topical kind of thing that comes up. I was like, "Oh, I just want to keep it simple. I really don't want to think about this sort of stuff on my day-to-day life if I can help it." So really, this is an example. If you have a 70 kilo weight, this is a rough example of how much protein you would need. It just means every meal, think about a little bit of protein. I don't want to overly complicate it beyond that. I know people are into protein supplements and everything like that, but personally, I'm just like, look, just add a little bit of, like, if you eat chicken, meat and chicken, add a bit of meat and chicken, avocado, peanut butter, yogurt. Like, these are all protein sources. It does not have to be complicated. Eat a colorful diet. Again, don't like be too prescriptive. It's just not my style with it. But just eat lots of colors, lots of variability, and you're actually doing pretty well. So movement, again, obvious, like movement does not have to be prescriptive exercise. It just means not staying in one place for too long. So that's absolutely fine to incorporate it. And a bit of strength training, like if I could give advice to myself in my 20s, it would be get chunky, start lifting some nice heavy weights now. And I definitely missed the boat a little bit on that one, but I do try and incorporate it, and it's something that we can make a small change there. So complementary therapies, like, look very popular, and I know why. Like, they have lovely marketing. Like, I look at the brands and I'm just like, they look really pretty and they look really attractive. But a lot of them are just very expensive, and they're at doses that are actually sub-therapeutic doses. So they're much smaller doses than we necessarily see any potential benefit in trials. And you have to be quite careful because they're not standardized preparations. So, like, one set of supplements does not equal the same. And I can't I always feel like, I'm like, look, I can't really advise accurately here because they're all a little bit different and they're not all trialed in the same rigorous ways that medicines are. Yoga, part of this, actually is really beneficial. It's a really good thing to do if you can. It's not for everybody, of course. So I kind of put in this slide, I was like, okay, I'll put some of the popular ones that people talk to me about, okay? The main thing is, if you are on these, please tell us, because some of them are not suitable for breast cancer, okay? They are a little bit concerning in terms of their safety, and they're not regulated as well. So just do tell people, particularly plant-based estrogens, black cohosh, and all of those ones, they can have interactions with things like tamoxifen and stuff. So you do need to be a little bit careful. Natural does not equal safe. Magnesium, and all of those I have the least amount of issues with, to be honest. There is a biological plausibility of it working. It does interact with the sleepy GABA receptors in our brain. So yeah, maybe there's something there. Personally, omega-3 and omega-6 may have some benefit for long-term brain function if you don't eat fish. Otherwise, maybe not. But yeah, it's just something to consider. What does have evidence? Okay, that doesn't have medicines in it. CBT has great evidence, like brilliant, really good evidence that it actually works and helps people. And so you should, if you're attending complex menopause services, you should have access to free CBT for menopause. I want you to have specific, good quality CBT. So you want to check that you have a licensed therapist on the IACP website, and preferably CBT specific to menopause. So medical non-hormonal. So what can be prescribed that does not have hormones? So particularly if you've got a hormone-sensitive cancer, these are the things that I'll be discussing, or your doctor will be discussing with you as their kind of first line. Doesn't mean it's the only thing, absolutely not. What I'll say is some of them tackle some symptoms of menopause better than others. So it depends what you're suffering with, if anything. And like, if you have flushes and sweats, or is mood more of your issue, is the vagina more the issue? Everybody's different in terms of what their predominant concern is. One I really want to like highlight, so I get really excited about, I'm a big nerd, but like, is neurokinin receptor antagonists. So these are things like Brca, so fezolinetant. These medications are really cool because they work on the thermostat in our brain. So our brain normally has estrogen there, right? And what estrogen normally does is inhibits that thermostat. So we remove estrogens, we take away our inhibitor, that thermostat goes right up and we get flushes and sweats. Neurokinin tackles the other side of it, okay? So neurokinin chemicals stimulate that thermostat. So we have a non-hormonal avenue addressing that thermostat. If we inhibit those, so neurokinin receptor antagonists, well, we're going a non-hormonal route to reset the thermostat. That's great. Like, we've never been able to do that before. So it's like, it has lots of promising studies in people who've had breast cancer that these medications are actually safe, they're effective, they're much better than placebo. They don't quite come up to menopausal hormonal therapy, which is still the most effective treatment for flushes and sweats, but they actually approximate it. They do need a little bit of monitoring. They're expensive, which is silly because they should be funded on the free HRT scheme, to be honest. I think they will be soon, but at the moment they're not yet. The rest of them are listed there. There's different ones. Like there's different ones that work for different things. There's bladder medications that have a side effect of reducing hot flush and sweat. They also help your bladder. So there's lots of ones there that can be very, very useful. The main thing is to have a chat about it yourself and see what symptoms are a problem. So that's it too. That was just for me. I just like the pictures. So medical hormonal, so menopause hormonal therapy. Okay. So like this is kind of like not relevant to everybody, but it's still worth knowing about. So what is it? It's an estrogen and a progestin. The estrogen is for your symptoms, and that there's a common thing out there that progesterone is for the symptoms. The majority of the time, not. Okay. So the estrogen is the dominant player for the symptoms, and the progesterone is there to protect the lining of your womb when you're taking an estrogen. There are some side benefits to some progesterones in helping sleep, and there's also a contraceptive benefit for things like the Mirena coil. But predominantly estrogen is your main one for your symptoms, and progesterone has a protective effect. They are not contraceptive by themselves. They're good for your symptoms, they're good for your bones, and those are the big indications. They're also good for people who have had a menopause earlier than we'd like them to protect them long term against their heart having problems, their brain having problems, and their bones having problems. So these are the kind of big indications for menopause hormone treatment. So what I say to kind of reassure a lot of people, because a lot of people are understandably concerned, they've had their risk reducing surgery. The last thing they want to do is take on something that has risk. I have so much nice reassuring data to say to people that there is no reversal of your risk reducing surgery when you take menopause hormone treatment after your risk reducing surgery until the natural age of menopause. We say 51. It sounds a bit arbitrary, but that's the natural age of menopause. Does that mean you have to stop at 51? No, but it means we have to have a chat, okay? Because then we have to think, okay, there are some additional risks that we need to think about, but we've done all the good, hard work of keeping everything nice and healthy up until this point. So we have to see where you are symptom-wise, which may be no symptoms, or it may be a lot of symptoms, and we say, look, let's continue. But just to reassure people that this is certainly very, very safe and actively recommended for you. If your womb is gone, so if that is gone, you do not need a progesterone. There are some exceptions to this. So if you have had endometriosis, so you're working with lots of endometriosis lesions outside the pelvis, we may need a progesterone here, and that's a chat to have about it. Also, if you've had endometrial or womb cancer, there may be a benefit, even if your womb is gone, to giving you a progesterone there. Okay. So the estrogen, how you give the estrogen matters. So we're thinking patches, gels, and sprays for the vast majority. There are tablets, but the tablets are associated with blood clotting risk, so leg clots and lung clots. But if you give the estrogen by the skin, it is clot neutral. It does not reduce your risk of blood clots. So if you've someone who had a blood clot in the past, it's not going to lower your risk, but it's not going to add to it more, whereas oral estrogen would add to it. So the progestin. There's various ways you can give this. So you can give it if you're someone who's still having periods. We want to allow the body to bleed. So we give it 2 weeks on, 2 weeks off. There's some modifications in there, but that's an oral progesterone tablet, which has no blood clotting risk. So don't be worried about that aspect. And you take it 2 weeks on, 2 weeks off, what we could call sequentially, to allow the body to bleed if it needs to. There's another way, which is one Mirena coil. And again, that may not be suitable for everybody or may not be something that they want. So that's absolutely fine. The Mirena is also contraceptive, so if that's applicable to you, that's great. And the Mirena is good for very high doses of HRT as well, so it has lots of good uses. There is a combined patch if you are someone who does not need to bleed, that can be very useful. And then there's a way we can make a kind of sequential patch as well. So it's confusing. It is but there's lots of different options, but I actually quite like that because it means we're more likely to find something that suits the person in front of you. So personal estimation of risk is really, really important, because everybody comes to the table with a different risk. First of all, what are they working with genetically? What has already happened to them? What are their lifestyle risks? And what's really importantly, and this is kind of something I try to gauge with people, is like, what's your personal tolerance with risk? You know, some people are very risk averse and some people are actually quite comfortable with risk. Symptoms are so difficult for them that actually the risk starts going down as being an issue and the symptoms start taking first place, and that's absolutely fine. When we do talk about a small increased risk of a breast cancer, again, when you have BRCA, your biggest risk, unfortunately, is your genetic risk, okay? Does HRT massively add to that risk? Probably not in a major way, but you are working at a higher baseline. So that's something that we just need to consider, and it's an individualized discussion. I think you've gone over a lot of the kind of risk assessment tools, so I won't go too much into them. There are a few other risks with HRT. We talked about the clots being with oral estrogen. Some people don't tolerate HRT. That's not really talked about, but actually it can give you breast tenderness, bloating. Like, it doesn't work for everybody, like everything. It really just doesn't work for everyone. Nausea can be another side effect. Irregular bleeding is common. Sometimes that needs to be investigated if you have a uterus in particular. May not help your symptoms is the other thing. So it does not help absolutely everybody. The other ones are not too much, I won't go too much into them today. This is something that a lot of people will see, and I kind of put it up. It's just to estimate, like, the HRT menopause hormone therapy really doesn't massively add to risk. It's small, okay? Lifestyle factors, so if you drink more than 1 glass of wine a day, or your BMI is in the elevated range, this is more significant to you and your personal risk of breast cancer than taking menopause hormonal therapy. This is very busy. So I just want to say that there are different types of estrogens. Okay, so different gels, different patches, and sprays. They come in different doses, and there's different equivalencies across. Okay. Your progesterone should be in proportion and match your estrogen. So if you have a uterus and you're taking progesterone, or you're taking your progesterone for another reason, you should have everything in balance between the two of them. So if you're moving up to higher doses, your progesterone should also follow that path. These are just some pictures of kind of like estrogel. So the gel pump dispenser would be very common. The Zeto spray to the forearm, Divigel sachets, patches, tablets. So these are the different types of estrogen, okay? Tibolone, so I mentioned Tibolone in case you've heard of it. It's a little kind of oral tablet. It has estrogen, progesterone, and a small amount of androgenic, so male hormone properties. It is not for everybody. It's not for people who've had a previous breast cancer unless they absolutely wish it, but there is a small increased risk of a breast cancer recurrence with it. So it's not one that I certainly would actively recommend. And because it's an oral estrogen, in people over 60, there might be a small blood clotting risk associated with it. Testosterone. I kind of chatted about this before, but in Ireland, I'll go to the next slide actually. So in Ireland, these are the products we predominantly use to give testosterone. There is a female one, and which is packaged nicely and kind of suitable at the female dose, but it's called Androfem, but it's from Australia. Oh God, okay, my red light just went on. I'm very flying. I'll keep flying. But anyway, it's from Australia. Really expensive to bring it in, so we tend to use the male hormone. I really want to say this, don't forget your vagina, okay? So please do not leave your poor vagina out. It is really impossible to have good sex drive, libido, and everything like that, or even just to feel well when your vagina feels like a crisp, okay? So don't, sorry, I talk about vagina all day, so I forget that not everybody like you will. But with it, lubrication, so lubricants, moisturizers, lubricants during sex, moisturizers otherwise, with non-hormonal options, coconut oil can be really good. These are some websites. Again, you're more than welcome to request these slides for information particularly. And then vaginal estrogens. These are so safe, okay? They're not absorbed into the body at all. They are safe after breast cancer. They're safe after estrogen receptor positive breast cancer. Take them if you need them. The recommendation is the first line stuff, so the non-hormonal for sure. But by the time people get to me, they've usually tried that. So we're in with the vaginal estrogens. Lots of forms, tablets, pessaries, gels, lots of ones to discuss. The ring is not easily available in Ireland, but I put it up just in case that ever changes. And then there are a few other options. There's a tablet you take for your vagina, and there's a vaginal DHEA, which is kind of broken down into a testosterone as well, which might be good for collagen. Limited studies in breast cancer patients, unlike the ones that I have for the localized vaginal estrogen. So it's not my first go-to if you've had breast cancer. Bones, bones, bones. Don't forget you have bones. You can't see them. Sometimes you can't see the problem until they break. So do not forget they exist. Take your vitamin D, wear your weights, and we should be good. And if you have an early menopause, just take that HRT until the natural age of menopause, because if you ignore your bones, frailty is coming for you, and nobody wants that. Okay. Sarcopenia, muscle wasting. Again, the biggest evidence is towards your lifestyle and vitamin D. It's actually not HRT. HRT is not really shown to reverse that, unfortunately, but it's still something to know about. Your skin will change in the menopause for sure. Does HRT help that? Case by case basis. No strong evidence that it does, definitely. Certainly don't go putting random estrogen creams on your face. Not a great idea. You're better off investing in a good SPF, to be honest. If you want to choose your evidence-based option, it's SPF. Female cardiovascular health. Oh my God, like all the studies are on like white males, which is fine. but like there was a lack of recognition about female cardiovascular risk factors. These are so important. So kind of gestational diabetes, you have history of a preterm birth. These are things that could give us a window into potential issues that you're going to face in your midlife. So really important to kind of think about them and address what you can. And again, won't go too much. Dementia, if you have an early menopause, you taking menopause hormonal therapy will reduce your risk of dementia, okay? Because that's not the way things ideally would have been. There is no strong evidence that taking menopause hormone therapy later will reduce your dementia risk, okay? Much more important to address the lifestyle factors than to do that. And I think I got wrapped up a little bit at the end, like I was still at the start, but that's it anyway. Any questions or anything else? Well, I think
Dr. Fagan is going to stay for Q&A after the next speaker. Is that okay? So thank you so much. Wasn't that fantastic? Yeah, it's amazing. Yeah. Really a lot of questions. So yeah, I'm getting the wand waved at me as well. So remind me that to tell you all that we do have the show and tell going on from 12:45 to 2:10 in the Sarsfield room. And can I ask the lovely ladies who have volunteered to be models for the show and tell to make themselves known to Fiona at the end of the room, okay? Thank you so much, Fiona, and thank you again, Dr. Fagan. That was just fantastic, lots of information. So do write down your questions. We'll have Dr. Fagan up on the stage after the next speaker, and we'll have several of the speakers up here on the stage so you can ask your questions. But without further ado, next up, we have Dr. Louise O'Driscoll and Dr. Christina Cahill. And Dr. Louise O'Driscoll and Dr. Christina Cahill are going to talk about psychological well-being and hereditary cancer risk, what the evidence tells us and what to do with the evidence. So we're delighted to have both Dr. Cahill and Dr. O'Driscoll here. Dr. Louise O'Driscoll is a principal clinical psychologist and clinical lead in psycho-oncology at St. Vincent's University Hospital. Her clinical and research interests focus on supporting people to live well across the trajectory of cancer from hereditary risk to advanced illness. Louise was one of the principal investigators on the Irish Cancer Society funded study investigating the psychosocial needs of hereditary cancer risk patients in Ireland, and this led on to the development of dedicated pilot psychology services with St. Vincent's University Hospital, Dublin. And lots of our Brca peers and Brca ladies were involved in that study, and we were delighted to support that study. Dr. O'Driscoll is passionate about advocating for the psychological needs of patients and using clinical research to inform policy and practice. Dr. Christina Cahill is a senior clinical psychologist working in cardiology psychology at St. Vincent's University Hospital. Prior to this, she worked closely in the development and evaluation of a dedicated psychological service for people with hereditary cancer risk, supporting individuals and families navigating Brca and other inherited cancer risk pathways. Her clinical and research interests focus on the psychological impact of genetic testing, navigating uncertainty, adjusting to inherited cancer risk, decision-making around risk-reducing options, managing health anxiety, and supporting family communications. So delighted to welcome to the stage, I think, are you both coming up together, ladies?
I think I'll come
first. Okay. Dr. Louise O'Driscoll.
Hello, everybody. So it's more time when your bio is read out.
Great bio.
Very generous, but more to write. So look, Christina and I decided to split this talk for the first 15 minutes to provide feedback on the research that we've done over the last few years that many of you may have contributed to. And I know from our conversations with Bernie that many of you were keen to hear about what we found out. So I'm going to do that. I'm going to do the very dry research bit, but I think it's fascinating. And Christina's going to talk to you a little bit about some of the strategies that we use as psychologists and that we work with people to use to manage cancer risk and to manage the anxieties associated with that. So if I could get a flag at my halfway point, that would be helpful, because I need to remember to give Christina time to do her bit. So look, I've been working in psycho-oncology for 19 years. And the reason I do this work, and particularly have an interest in hereditary, is the people I've met. And the artwork you'll see there is from a lady I worked with for many years called Helen, who is happy for me to share her story. But she did this beautiful artwork. Helen's an artist as well as someone who lives with Brca. There's a pathogenic variant. And this artwork represented what it was like in her mind to find out about her hereditary familial risk, and just the head spinning impact of that, and the sense of constantly being watched medically and needing to watch, and what it was to constantly be in this surveillance pattern and then engaging prophylactic surgeries. So Helen's one of the reasons that we've done this research. And I suppose we've heard such beautiful and informed presentations today from Karen and Shauna that give us a lot of numbers, and risk is often put in numerical order, right? But as a psychologist, I know that that number means something different to every person who hear it, because when we hear that number, we hear it in the context of our own life story, the context of our family story, the people we've known, we've loved, we've lost with cancer, and how that's been managed. So even though the number might be the same for several of us in this room, how we experience is entirely different. So as a psychologist, this is I suppose, a fascinating and interesting landscape. And I've always been aware that all of evidence in the world how to manage that number medically will never, and it won't do everything. It will only ever give us one side of the picture, because the other side is how am I, the person interfacing with that number, what does it mean, and how do I manage it? We've heard a lot about kind of the policy landscape, cancer strategies and genomics and genetics movements that have happened in Ireland in the last few years. They've really informed why we did the research that we did in Vincent's. We wanted to get really solid data for why the NCCP should recommend psychological care as a core component of care for hereditary cancer patients. So what we know from the literature, we know that about 20 to 25% of people who live with high familial risk experience a clinically significant level of psychosocial distress. The main three categories of distress are cancer-related worry, anxiety, and depression. We know that there's factors that impact that, like the meaning of result in my family and the inherent uncertainty of what those figures mean for me. They'll impact what our distress looks like and how high it is. We know some people are more likely to experience distress than others. Some people need psychological intervention and will need it on an ongoing basis or on a sporadic basis. Other people don't need that. That's fine. We have information about who's more vulnerable and who needs more support, but we're often not using that information in our clinic settings. Most of the literature that's out there on psychological adaptation to high familial risk is on Brca confirmed people. That doesn't reflect who attends high familial risk clinics in Ireland. So in Vincent's, high familial risk clinics are mostly attended by people who don't have access to genetic testing or who haven't historically, because the access to genetic testing has been really limited in Ireland, and often something that people have to pursue privately. So we don't know about the people we don't know about, our clinical services lag far behind best practice, and our genetic services often occur separately from oncology teams. So that further psychosocial integration would be beneficial, according to Espen and Cohort, who are big researchers in this area. Importantly for me, when I saw the work the NCCP were doing on the model of care, and the recommendation for psychological care is fantastic, but it makes it, before the recommendation for a new post, it kind of made an assumption that psycho-oncology teams could support this population, but psycho-oncology teams were not given, I suppose, a level of staffing that would also support this population on top of the people who have cancer already, and we need to bear that in mind. So we did this research. What we aimed to do with three things. We wanted to ask people with high familial risk, what do you need? What are your psychosocial needs? We wanted to ask healthcare professionals, what were their psychosocial needs, what they felt the psychosocial needs and gaps were. And then we wanted to design and run a survey and say, look, if we actually do this, we put a psychologist in a clinic, does it help and how does it help? So lots of big aims that work went on for kind of many years and finished last year in full and has been written up. I'm just going to talk about the two aspects. I'm just going to talk about what people told us they need and does a clinic work. So the what people told us they needed, the first thing we did was we asked patients attending the clinic in St. Vincent. So we wrote to about 400 people who said, briefly tell us what you need. And then we did a full psychosocial needs assessment nationally, both in the clinic in Vincent and a lot of you have completed online questionnaires. Of the people we wrote to about 400 people. We got 250 responses. So people were really keen to tell us what they needed. Mostly we get about 20% response rate. We got like a 60% response rate. 58% of people were 40 to 49, and most were married, 67% were married, 81% had children. 82% of people said, look, distressing and upsetting thoughts about my cancer risk bother me sometimes or often. 60% of participants felt that having an increased genetic risk of cancer impacted on their emotional well-being in a negative way. Interestingly, of the 40% who said this doesn't impact me negatively, 20% of them said it did at some point. So altogether, about 80% of people are saying this impacts my emotional well-being in a negative way. We asked people, what are you interested in getting? 84.6% of people were interested in getting psychological support. Most of them, 72%, said, look, a one-off consultation would be great. A good percentage, 47%, said, no, I'd like individual therapy. I'd like to be able to go back to someone immediately and talk about this. 39% said peer support, and about 20% said couple or family support. And the key areas of need identified were support with decision-making, strategies for coping with stress specific to the increased cancer risk, peer support, and advice on how to communicate with families. So then we did this national needs assessment. Those of you who did it will know there was a load of questionnaires. Thank you for your time. We really appreciate it. There was about 43% did it online and about 56% did it in the clinic in Vincent's. So there was a spread across genetic risk in this group, but most of the participants had a hereditary risk of breast and ovarian cancer. 64% had no confirmed genetic variants. So exactly what we thought at the beginning is that most of the people going to these services in Ireland haven't actually had confirmed genetic variants. They've been waiting for testing. They're referred for testing. 95% female, 3% male, 2% non-binary, and a mean age of about 42%. So interesting, what we found in this national sample was that the Irish figures kind of matched international figures. About 23% had moderate to severe anxiety. I need to stress moderate to severe anxiety, and the measure that we used would meet clinical thresholds for a psychiatric diagnosis of general anxiety disorder. So we're not talking about like a small bit of health anxiety or a little bit of worry. We're talking really significant anxiety that impacts your day-to-day well-being, your quality of life, your function. So that's about 23%, which is quite high. 18% met criteria for moderate to severe depression. A cohort of people said, look, we really don't have adequate psychological support. We feel we're very inadequately supported psychologically. And if you said that, you're more likely to be anxious and depressed. And it makes sense. And participants recruited from the clinic in Vincent's were more than twice as likely to say they had enough psychological support. So it seems like being attached to a clinic, having the same place that you go back to with great A&P, works in Brca there, that they and those patients can be referred to like oncology services. So having reliable care pathways and access to additional support if you need it makes it more likely that you say you're doing okay.
I think it's a good time to switch over. Let's do this.
Christina, maybe 2 seconds. Is that okay? Because I need to tell you about this. So Christina ran the service. It was operational for 15 months. 51 patients were referred, 39 attended in person. We really need to know if you put in the resource, does it help? Because if you're going to fund a psychologist, and we're expensive, you need to know it works. And the people who attended the clinic, 45% of those had moderate to severe levels of depression. So the people who were referred really needed to be referred. 63% of them had moderate to severe levels of anxiety. 75% were in the clinical range for depression, and 93 were in the clinical range for anxiety. So, like, there's a cohort of people here who are living with hereditary cancer risk who has a very significant psychological need. Sometimes people can say, this is the worried well. This is not the worried well. These are people who are suffering. At discharge, most were in the subclinical range. 65% were subclinical on anxiety, 70% were subclinical on depression. Meeting with a psychologist for individual one-off or recurrent intervention significantly reduced people's experience of anxiety and depression. It works really well. And Christina is a really good psychologist. So the take home from that. People were really happy. 100% were returning. 87% said the number of sessions met their needs. 93% found the service addressed their specific problems, and 100% reported that engagement with the service provided them with the ability to deal with their problems more effectively. It's what we want people to think. I'm going to skip over that, and I'm going to go to where to from here. Look, we heard this morning from the NCCP about the recommendation that they made this year for senior psychologists to be attached to regional centres. They've been really receptive to the data we've provided. When I'm on the implementation group for the hereditary cancer model of care, that recommendation is fantastic. But the NCCP don't get to decide where the money gets doled out. Money for these services now gets doled out at a regional level through things called a regional executive officer. We need to lobby for that money to go into these posts being filled, because a recommendation from the NCCP for there to be a post is only the first step. The next step is everyone who, you patients have a huge voice, us at the regional cancer centres, lobbying for that recommendation to actually get turned into funding. So I'm going to go now.
Hello, everybody. Okay, so I am just going to speak to you a little bit today about, I suppose, general themes that would have come up in my work with patients, I suppose, in the service that Louise was talking about. And I'm really conscious that it's really hard to do a lot of this justice. It's really hard to condense so much of this information into such a short period of time. So just bear this in mind as I'm going through slides, that, you know, really it's just going to be kind of very brief overview rather than covering any topic in a specific way. So I think lots of people in this room will probably recognize that when you first learn about BRCA or any hereditary kind of cancer risk gene variant, the focus understandably comes on maybe a lot of medical information, a lot of practical stuff, you know, so it's surveillance, it's surgery, it's risk percentages, like treatment decisions. But underneath or alongside all of that is a very human emotional experience. People are often trying to process fear about the future, difficult decisions, changes in identity or body image, family implications, and the emotional impact of uncertainty. And I really want to emphasize today, you know, I know Louise was talking about, you know, in some of the research and what we were finding in terms of kind of rates of anxiety and depression. But I also do want to say that distress in this context is not a sign that someone is coping badly or is not coping with this. This is a very understandable response to something that is genuinely significant. So I suppose I'm going to go through some maybe kind of practical tools that can help support coping and emotion regulation and decision making. So I think one of the most important things that we do as psychologists in our work with clients is really just normalize emotion responses. I think everybody can probably agree that when you learn about BRCA, you can experience a variety of different emotional responses to this. And you might experience them all at once, or you could experience them in waves and at different points throughout your life. For some people, they might become highly aware of their body and much more aware of their body than they had been previously. So you might become kind of very aware or tuned to kind of different bodily sensations or different health changes. For other people, they might struggle with decisions around surveillance versus preventative surgery. Lots of people carry concerns about family members or their kids. And underneath all of that is uncertainty, which human beings generally tend to find very difficult. So it's really important as well to remember that lots of people can feel quite isolated in this experience. They may feel that others may not completely understand what it's like to live with ongoing risk awareness. So part of what we do and part of psychological support is to help people feel less alone, less overwhelmed, and more emotionally equipped to navigate, you know, what lies ahead. So anxiety in this context often tends to become very future focused. People might find themselves thinking, what if something is missed in my mammogram or my MRI? What if I make the wrong decision? I need certainty before I can relax. And the difficulty in that is that your brain starts treating uncertainty itself as being dangerous. So one practical tool that can help in moments of overwhelm, let's call it the 3-step acceptance reset. I don't actually call it this myself, but just for practicalities. So step 1, just name the emotion. Like for me right now, I feel quite anxious because standing up in front of a group of people is always nerve-wracking. I feel anxious. Why is that important? Sometimes even the act of labeling the emotion helps to start regulate your nervous system. Step 2, locate it in your body. Where are you feeling it in your body? So for me, yeah, there's a bit of tightness there in the chest, and my stomach is doing that washing machine thing where there's butterflies. Sounds really simple, but what that does is it shifts the tension away from spiraling thoughts into present moment awareness. Step 3, return to now with grounding. And grounding can look different for every person here. Some people prefer a internal focus where you might kind of use breathing or kind of focusing with your feet on the floor, your bum on the chair. Some people prefer a more external focus grounding where you use your senses, you know, the 5, 4, 3, 2, 1. Noticing 5 things you can see, 4 things you can hear, 3 things you can touch, 2 things you can smell, and then 1 thing you can taste. The aim is not to eliminate anxiety completely, it's to help your nervous system feel safer to come back into the present moment. Oftentimes people are trying to maybe logic or think their way out of uncertainty, but grounding works, and we know it works by helping your body recognize, I'm safe right now in this moment, and that's okay. So, as Louise was talking about, we really found in our research that decision making is one of the biggest psychological burdens in hereditary cancer risk. So people are weighing up a lot, you know, surveillance versus surgery, fertility considerations, timing, body image, sexuality, relationships. There's a lot. And people, you can become stuck in trying to find the right decision. You can imagine psychologically, this creates so much pressure because usually there is no perfectly certain option. So a helpful reframe that we would use is there might not be one universally right decision here, but there can be a decision that best fits a person's values and circumstances at this stage of life. So a tool I often use with clients that I work with is a values compass tool. So instead of asking yourself, what's the right decision here? What's the perfect decision? We ask instead, what matters most to me right now, this point in my life? So for some, it's about being present for my kids. It's about reducing anxiety. It's preserving fertility, whatever that might be. Once you are able to identify what's important, choosing the option that best aligns with that values at this stage of life. And really importantly, decisions are allowed to evolve over time as circumstances and priorities change. We've talked a bit about uncertainty, and we know a huge amount of distress in hereditary cancer risk comes from trying to eliminate uncertainty completely. People might find themselves overthinking and body checking and, you know, the what if thoughts, repeatedly seeking reassurance and finding it really hard to mentally switch off. And again, all of these behaviors make so much sense psychologically. They're attempts to create safety and certainty. But unfortunately, reassurance only tends to work temporarily. The anxiety will always return. So one gentle but really important reframe is that we cannot eliminate uncertainty completely. But what we can do is strengthen our ability to cope with it. So one question I would often ask, you know, people I work with and continue to work with is, what has helped you survive difficult times before? Anxiety has a bit of a tendency to narrow our focus and makes us forget all of the wonderful strengths we possess, the kind of the coping mechanisms we already have, the supports and relationships in our lives, all of that kind of stuff. The goal is not to become someone who doesn't feel afraid. It's more to feel more able to carry uncertainty without it completely taking over your life. Am I doing on time? You're fine. Okay. So, another kind of challenge, you know, and this would be a regular theme that would have come up in my work, is communicating with family, like really important. So people often worry about, am I scaring people? Am I going to frighten them? Are my kids, if I talk to my kids about this, are they going to be worried about this and thinking about it? What if family members react badly? You know, what if someone doesn't want to know this? And all these conversations can feel really emotionally loaded because they involve love and fear and responsibility and vulnerability. So when you're talking with adults, maybe in your family, one helpful principle is sharing information, not panic. You're not passing on fear, you're passing on information, knowledge, and empowerment. And really importantly, you don't have to convince other people of what to do and how to navigate that. That's not your job, that's theirs. Your role is to communicate information openly and compassionately. When you're thinking about having conversations with kids, what we find is that smaller ongoing conversations usually tend to work best over the kind of the big serious sit down. Simple language, you know, so you might say something like, there's something in our family called a gene change, and that means we have to keep an extra eye. What we find and what we know from the research is children often tend to cope better when information is honest and calm and age appropriate. We also know from the research in general that open communication actually tends to reduce anxiety and fear rather than increasing it. And finally, kind of another theme that would have come up quite a lot in my work is self-criticism. So people would often say things to me like, I should be coping better. Why am I struggling so much with this? I need to be strong for everybody else. And I think as we've kind of demonstrated in the Louise's part and hopefully with this talk too, that living with hereditary cancer risk involves chronic uncertainty, repeated decision-making, lots of medical appointments, family concerns, and ongoing emotional activation. So self-compassion becomes really, really important. A gentle reminder, you didn't get to choose your genes. You're responding to something that is really significant and is genuinely difficult. A practical exercise is how would you speak to someone you love if they were in this exact situation? Often we're really good at offering other people kindness and understanding and permission to struggle, but we're kind of diggles at being able to offer that to ourselves. So self-compassion is not about giving up. It's not self-pity. What it's actually doing is creating an internal environment that supports coping and resilience. Support, connection, rest, and kindness toward ourselves. None of those are weaknesses. They're all part of sustainable coping. So, just to finish, living with hereditary cancer risk is not only a medical experience, it's a deeply emotional and psychological experience as well. People are navigating a lot. Could be all at once and at multiple points throughout their lives. We know from our research that psychological support can help navigate that journey. And what it can do is help people regulate anxiety, make values-based decisions, communicate more openly, learn to tolerate uncertainty, and respond to themselves with self-compassion. Thank you.